Dr. Schwett, Dr. Todd Schwett at Mayo Clinic in Arizona, did a fabulous imaging study where he showed that there are actual differences in the volumes and the of certain parts of the brain in people with post-traumatic headache and people with chronic migraine. So already we're seeing a little bit of structural difference. And then another great study by on rats with TBI that were exposed to either blast injuries or actually direct contact injuries to their head showed that there was in fact a difference between how their brains reacted to each one of those injuries. So already we know that that there are differences between regular post-traumatic headache and migraine, and within post-traumatic headache we can see some interesting trends showing that blast injuries are in fact different from blunt force injuries. So let's see here. Let me get to some questions here, since I probably spent an awful lot of time trying to figure out what on earth happened to the internet. So let's see here. A lot of people finally being able to get back in. Third time's a charm, sure is. All right. So how often should a migraine sufferer get scanned? Excellent question. That's coming from Judy Bushway Essig. Sorry about. I think I'm still on. Can't quite tell because the video feed seems to be gone, but okay, fabulous. So not sure why I can't see myself, but I don't really want to see myself anyway. All right. So back to your question, Judy. Thanks for reassuring me that I am still on the air. All right. So how often should someone get scanned? You know what? I think one problem that we have, at least in the way we practice medicine in the U.S., is that we tend to overscan people, actually. So it's not that unusual for someone with concussion, let's say, or even with many headache disorders, to go into an emergency department, and the next thing you know, they're getting a head CT, or even in the outpatient setting, next thing you know, you're getting an MRI. When in fact, if symptoms seem to be recovering and the exam is normal, and by exam I mean a good detailed neurologic exam, generally speaking, you can probably get away without having a scan of your head. But let's say that you already come in with a scan, and this happens all the time. I would say a large majority of my patients do actually come in with a scan already. How often do they have to be rescanned? Really only if there's ever any major change. I think we get too much into the habit of saying, well, you know what, I'm not any better, nothing's any different, I need another MRI. And that's really just not the case at all. One of the questions that comes out of that is, well, maybe this time you can find something because all my other MRIs have been normal. And as frustrating as that can be, I can tell you that it's because MRI is just not sophisticated enough to see the abnormalities that you are experiencing down to the cellular detail. So it'd be almost like taking an x-ray of your head and expecting that to tell you something. Because we do have MRIs that are very specialized, really just used in research settings at this point, that can actually see abnormalities on a metabolic level and abnormalities at a structural level that a routine MRI cannot. But anyway, that's a very long-winded answer to your question about how often you should get scanned. Maybe once if you're not getting any better, but with a normal neuro exam and a stable history, really that's about all you need. Let's see here. What other questions do we have here? Can PTSD cause migraines? Well, that's an interesting question because I wouldn't say that they directly cause migraines. This is from Katie Gomez. I would say that PTSD and a lot of other issues like depression and anxiety occur quite frequently in people with migraine. And in fact, what may happen when two things occur very frequently together is that sometimes there is a relationship where one tends to exacerbate the other. So I do see people that that have both anxiety and migraine, And when their anxiety gets worse, their migraines get worse. When their migraines get worse, their anxiety gets worse. And it works the same way for PTSD. I don't know if I would say that it would cause it, but especially post-traumatic headache, people do note a lot of issues with PTSD, especially in our deployed military personnel. And so I do see them frequently together. Let's see here. A couple of people reassuring me that I am loud and clear. Fabulous. Wow, constant auras such as Alice in Wonderland indicate. That's from Missy Bowers. Missy, that's a very complex question. Let me see if I can try and sum it up very succinctly. So the issues that happen in aura involve what we think of as a wave of cortical spreading depression over the surface of the brain, and it moves actually quite slowly. And what we do notice is that there is a almost like a wave of increased blood flow that is ahead of that cortical spreading depression, and then it's followed by a decrease in cerebral blood flow. And at the same time, we see a lot of ion shifts within the brain that tend to produce the sensation, the visual sensations, and the visual distortions that people get in aura. Now, this can occur in different parts of the brain, and when it does, sometimes it produces other things that are non-visual. Anyway, what does it indicate? Well, it indicates that there's a lot of metabolic and also vascular issues that are going on in the brain whenever we see issues with aura. Interestingly enough, we see very similar metabolic changes, and we see very similar vascular changes with a decrease in cerebral blood flow, for instance, after concussion. And that's, again, where there's a little bit of an overlap between what we see after a head injury and what we see in people with migraine with aura. What happens if it's persistent, as you've suggested? Well, it suggests that this wave is just continuing to build on itself and is just continuous, and that someone needs to find a way to maybe interrupt that cycle a little bit. Let's see here. What can you do if you have hemiplegic migraine and post-traumatic headache? And that's from Fendi Ha. Another great question. So I would say anyone with a really super rare and debilitating headache subtype like hemiplegic migraine really needs to get to a headache specialist. So I would, there are a lot of specialists out there that treat headache and treat it very well. But at that point, we need to find someone who can adequately prevent those hemiplegic episodes from coming on, and someone who has the ability to ask the right questions and know how to follow you. Typically, that is a headache specialist. And this is a good time to note the fact that headache specialists come in all flavors. They don't have to be neurologists. I know a lot of just really fabulous primary care headache specialists. So get yourself to a headache specialist. Let's see here. Bad concussion from fall on ice last year, still suffering, using rizatriptan, still under neurologist care. And before I lose it, that's Lisa Hammond. Yeah, you were about to fall off the edge of my screen there. Yeah, so still using rizatriptan, which is a migraine-specific abortive treatment for acute attacks. Makes me wonder, how often are these attacks happening? And perhaps would you be someone that would benefit from being on some kind of preventative medication? Sorry for such a short answer. These questions are really piling up on me here. But I would say look at prophylaxis. Sometimes that helps medications like rizatriptan work better, and sometimes that also prevents you from having to take it so often. Question from someone just fell off there. Catherine Thrift Winch. So my doc has never attempted to find out why I have migraine. Just pump me with meds to help them. Not so much. Should I go to a different doctor? Okay, so that is an excellent question, and one that I face every time. Well, not every time, but every week just about in my clinic, is people saying, okay, what is the cause? And it really gets down to the fact that people with migraine have a genetic disorder. They have problems that are occurring at a cellular level, and that's not something that you're necessarily going to see on an MRI or a CAT scan or in a set of routine lab work. But it doesn't mean that those normal imaging studies and lab results mean it doesn't mean that what is going on inside is completely normal. So, so when someone does a scan and a bunch of labs and rules out some of the major issues, I would say most of the time that's all someone needs to look at whether or not there's something secondary going on. Now, if you have a lot of other issues and a lot of other health issues and physical exam findings, well then yeah, maybe that that provider needs to dig a little deeper. But I can tell you that the majority of people with migraine have migraine as a primary disorder, and it's not actually being caused by something else. Let's see here. I'm just going to dive right into what's coming up here. Let's see here. I apologize that I'm missing a lot of your questions. Are coming in so fast that that some of them are just dropping right off the screen. So if I miss it, ask it again, and I'll see if I catch it on the second pass. Let's see here. I've had from Becky Bynum. I've had migraine from an injury from 40 years now, and I've developed Icepick migraine headaches with epilepsy. Is this normal for a migraine sufferer? Interestingly enough, migraine sufferers it's very common among migraine sufferers to experience these Icepick type headaches, these little jabs and jolts that can sometimes occur in between migraine attacks. And so about 30% of people with migraine will experience that. It's not unusual for someone with a traumatic brain injury to see an uptick in the frequency and the severity of their pre-existing migraines. And that includes an uptick in their jabs and jolts and their little Icepick episodes that can occur frequently in between attacks. So yeah, that's not too unusual, and I would certainly treat the overall headache picture a little bit more aggressively to see if that makes you feel better. Let's see here. Do I think CGRP will help NDPH? Excellent question from Katrina Shaw. That is, well, that is a great question, and one that I know a lot of researchers are working on at the moment. Physiologically, I think it makes sense. We do know that in both migraine and in post-traumatic headache that we do see a lot of release of CGRP that is sort of the substrate through which the whole pain process begins. And a lot of the new CGRP drugs for migraine seem to be working very well. I think that in theory they should work very well for post-traumatic headache as well. Connie Birdsong, I take Topamax. Excellent. That's a great preventative drug. As long as you're tolerating it well and not having any issues with it, and most people do tolerate it well, then I hope it's helping. We do know from some studies in the VA that actually Topamax, topiramate, just in general terms, does actually seem to be one of the few things that has perhaps some of the best evidence that it's helpful, at least in the VA population. Let's see here. Are there any headache specialists in the Newtown or Wichita, Kansas area? That's from Jody Sweetland. I don't actually know of any personally, but I would go to the American Migraine Foundation website, American Headache Society website, look for a provider, see if we can find someone in your area. And let's see here. It looks like the American Migraine Foundation just put an excellent resource guide up for individuals looking for looking to help them navigate the emergency room. Sorry, I'm trying to read a moving target here. Let's see here. Laura Ains Blanton. I had migraines since I was 7. I'm 46 now. Tried everything. Got my daith pierced. No more migraines. So I know I'm pronouncing that wrong. But daith piercing or daith piercing is a piercing within the ear that can actually abort people's migraines or prophylax people's migraines, according to some, right? And this is an anecdotal, sort of an anecdotal level of evidence where some people say it helps, some people doesn't, hasn't really been studied. In reality, the evidence for it is not fabulous. The American Headache Society has not officially supported it as a good prophylactic measure, but I can tell you, if it's helping you, that's really all that matters. And I think a piercing like that is a pretty simple, easy thing to try. That if you want to go for it, perhaps you would be one of those people that that it would work well for. So great to hear that, Laura. Let's see here. Silver Beth Salinas Medina. Oils have been helping. So essential oils. You know, interestingly enough, there does seem to be a fair amount of both anecdotal evidence and what we call open label evidence, where the people who are getting the treatment know what they're getting. Open label evidence that essential oils can work for some headache types. Again, I feel like that's a treatment that doesn't have the best level of evidence, but one that I don't have any issue with you trying. I am all for trying things that are naturopathic and homeopathic as long as they don't have the potential to harm you. And that one sounds like it does not. And if it's helping you, I think that's fabulous, because at the end, that's really what we want. We want people to get better. Let's see here. Oh my gosh, these questions are coming fast and furious here, and I know we're running out of time. Let's see here. Someone from the American Migraine Foundation, give me a quick heads up here for how much time we have, because we are 1 minute over at the moment. I'll answer a couple more questions if I can. Question about what are your thoughts to using cephaly to help treat migraine? Great question. That's from Stephanie Vanderploeg. So cephaly seems to be very helpful for a lot of populations of people. And again, like some of the other things that we've talked about, piercings, essential oils, I don't feel like that is a device that has an enormous potential for harm and has the potential to help. So I would say if it doesn't hurt your pocketbook too much, because it's going to cost you about $400 to $500 out of pocket, well, then by all means, go for it. It does actually have some studies to back up its utility for both prevention and for the acute treatment. So by all means, give it a try, and I hope it works for you. Let's see here. American Migraine Foundation, I see find help, and I apologize if I missed some sort of cue that we are about running out of time. Let's see here. Let me see if I can find a question that is specifically with pertinent to post-traumatic headache. A lot of migraine questions, which are great. And if I don't find any PTH questions, I'll get to the migraine questions. Okay. I'll tell you what, I'm gonna jump in for because I think this does pertain to post-traumatic headache. Melinda Kaufman is asking me, is Botox the best latest treatment? I don't know if I would say either best or latest, but it is. It seems to be a good one for some. Remember, everyone out there, that there are no treatments that are perfect for everybody, and Botox is one of those treatments that does seem to help a fair amount of people. And then there are some populations of people who don't get as much help as we would like. Interestingly enough, there are some good data again from the VA. A lot of people with post-traumatic headache there, that would indicate that Botox does actually seem to be pretty helpful for people with a more chronic form of post-traumatic headache, being one that lasts for greater than 3 months and does seem to have the appearance of migraine. So I would say that a lot of my patients that meet those sort of criteria do end up getting onabotulinum toxin A injections. Sorry, I hit the microphone there. Let's see here. Fabulous. It looks like we are kind of wrapping up. I apologize that we sort of ran out of time here. It looks like I had over 212 comments. Holy cow. It's a lot of comments. So I apologize. I wasn't able to get to everybody. But please feel free to reach out to the American Migraine Foundation. They can help facilitate some additional answers to some questions. I will try to go in and manually answer as many of these questions that I can over the next several days. Otherwise, you can DM me, or you can follow me on Twitter at Bert Vargas, B-E-R-T, Vargas, V-A-R-G-A-S, and perhaps we can communicate there. But we'll find a way to try and get to as many of these questions as possible. They were all fabulous. This is a really important topic, and I think the fact that we had so many people engaged is a real testament to the fact that it's a big problem, and a big problem that I hope we find some answers to very soon.